Lisa, who's a second-year neurocritical care fellow, and she's going to present the first case.
All right,
Okay.
thank you.
Thank you very much. Okay.
All right, so Dr. Silverman was kind enough to help us with one of our recent cases in the neuro ICU that we thought would be of interest to discuss as a group. We came across a few dilemmas and ethical issues, so as we go through this, if you could give us some insight as to how you might handle the situation. There are a couple of questions that we'll go through. So to begin, our case starts with a 27-year-old of Hindu ethnicity who had no significant past medical history. She had presented to the outside hospital after sudden onset of right-sided weakness. She was at home with her family in the middle of a conversation when she had the right-sided weakness, right gaze preference. She reportedly fell back and her family caught her, so there was no traumatic brain injury. But she did become unresponsive, so they took her to the outside hospital where, of course, a CAT scan of the head showed left temporal ICH and subarachnoid hemorrhage. She was then transferred to the neuro ICU for further management once they had seen the ICH and subarachnoid.
So I'd just like to, the ethics question was how to proceed when a family does not accept the brain death diagnosis and the patient is an organ donor. Okay, go ahead.
So I'll just scroll through it.
Yes,
Okay.
right. Go
All
ahead.
right. Okay, so on her admission, she already had non-reactive pupils that were 5 millimeters, so dilated. She had no cough, no gag, no corneals. So immediately on arrival, she was hyperventilated and given hypertonic saline as well as mannitol. The CTA was done and it showed no intracranial flow at that time. So also concurrently, an EVD had been placed when all of these other measures for intracranial hypertension were being started. And unfortunately, the EVD also had an opening pressure greater than 30, and it immediately clotted, so was non-functional in relieving any of the pressure. So this is a couple of slices of the CTA. So the vessels are clear in the neck, so you can see this is a CTA sequence. However, there were no vessels throughout the scans visible intracranially. So we had ICH and SAH that were present on the scan, but no vessel flow. So during the hospital course, within the next day, she underwent evaluation of death by neurologic criteria. She had no brainstem reflexes, just as we had discussed at the beginning on presentation. She had no cough, no gag, no corneals. Her pupils were fixed and dilated, and she did not take any spontaneous breaths during the conventional apnea test, and her carbon dioxide did have a large enough difference between the different ABGs. So this had occurred on Saturday, and the family meeting was held on Sunday. She'd been admitted on Saturday, and the family meeting was held on Sunday following the brain death exam. And there's a very large extended family of 15 or more people who had traveled to get there for that day. The Living Legacy patient advocate was present. However, they really didn't lead much of the conversation, or they didn't lead the conversation. They were just present as a patient advocate at that time. And it was disclosed that the patient was a designated organ donor on her license. So although she was declared brain dead at this time, the family had requested more time to process this information.
What had happened to her?
She had this spontaneous ICH and subarachnoid hemorrhage. She had no significant history at that time. And she really had no medical history. It just was a spontaneous bleed.
I have a question.
Yes,
If that patient was, let's say, DNR, like she signed a do not resuscitate, whatever, and then she died, can the family reverse it during CPR, for example, or if we had to know? Because I think that might fall under the same jurisdiction. You know, if she deems herself as a organ donor, can the parents revoke that after her death?
we go, what, the organ
The organ
donation?
donor, yeah, I'm kind of comparing that to a DNR. So if, let's say I deem myself DNR, something happens to me, can my husband decide, no, she's gonna be full code?
So-
When I'm not capable to make that decision anymore?
Right, yeah, so, good question. So essentially, actually, we have a case involving the advanced directive. So the short answer is no.
No,
If
okay.
you have left written instructions
Yeah,
to be DNR or an organ donor, the short answer is
okay,
no one could overrule that, or should not
okay.
overrule that. Okay, all right, good.
Okay. So, in addition to complicate things, as an exam had been done, the family had noticed movements of the body which were actually due to spinal reflexes. However, this can be bothersome to the family and be confusing when you do diagnose someone as brain dead and they are still having reflex movement. So that had to go into discussion with the family as well. So at the time that the family had been told that the brain death exam had been done and she was declared dead, they had requested a week to maintain her on the ventilator. They said that they understood that she was brain dead, but that they wanted to keep her on the ventilator to maintain her. They were very vague at this point in why they wanted her on the ventilator for a week. Initially, they actually had asked to keep her until January because they wanted to wait for a miracle. But then they, in understanding that this was an unrealistic request, they had said a week for them to process these things. But when they were talking, sometimes some of the family members would allude to waiting for a miracle. Some had said they were waiting for family to come from Guyana, which is where much of their extended family was from. Some seemed to not believe that she was actually dead and that brain death is equivalent to dead. And others seemed to be very focused on the ceremonies that might be going on in memory of her or surrounding her death. But it wasn't clear at the time. So this raised a number of questions when we were going through this, and especially in that initial family meeting and with these vague possibilities of why they were requesting a week, and they didn't really seem to want to disclose or be clear about which reason it was. So it raised questions amongst our team that we were discussing. So we had brought up to the family that she was a organ donor after she had been declared brain dead. And then they had still said they wanted to maintain her on the ventilator with the knowledge that she was no longer alive and that this could prevent her from being an eligible organ donor. So there's a question of what would be a reasonable time to sustain a body after brain death, whether that be in the setting of being an organ donor or whether that be in the setting of one of these other questions that the family members were bringing up, such as religious purposes or just requesting, waiting for a miracle or waiting for family to arrive. So there's not really a set standard or a set protocol for how long you can keep a patient on a ventilator. And there have been a number of discussions, and even in our protocols or guidelines, it says a reasonable amount of time. Like, it's fairly vague language. So we can say.
So what do you think? What is a reasonable time to wait? Family is asking a week. What are your thoughts? Yes?
I agree with the reasonable, that's quite arbitrary.
Yes, right.
From what Kristen told us, I do see the shift. I think just we neurologists know some psychiatry. So this is 4 stages of grieving process as a young, otherwise healthy woman who suddenly collapsed. So I think what family is doing spiritually and otherwise, they're just dealing with the stages of grief.
Right,
So some reasonable time is, so the family did transition from January, whatever time frame this happened, September, to 1 week. So we can just agree on some common grounds, the treating team and the family, that we will do it on a day-by-day basis, see where the electrolytes are, see where the intracranial pressure is.
Oh.
I would not commit to one.
well, she's dead now.
Yes, she's dead.
Okay.
So I can, in my field, I can relate to this case. I think I know by law, by Maryland state law, once the patient is brain dead, we can just declare the patient brain dead, and we can pull her off.
That's right.
And I don't think we will be held as treating physicians responsible in court for doing otherwise by the family. But that being said, I don't think we doctors are seen in society as pulling the plug. So we have to wait on that reasonable time frame, 1-2 days, if not 7 days. Maybe
Okay,
5
other thoughts? Yes.
In terms of honoring the patient's wishes, I would want to know more about the viability of her organs in this situation.
All right, good question. Anybody here from Living the Legacy? Guess it didn't show up, but, there was a concern about the viability of the organs. So that's one concern. Other concerns as well? Yes.
How long can the organs stay, how long are organs good so that way they can still be donated?
Well, I mean, the patient is getting adequate flow, to be sure, so that wasn't a pressing issue. But other issues that would warrant, I mean, how many people would wait a week? Or what is the undeclared standard of how long we should wait?
And does it vary with different reasons? So if you were waiting just for the family's like acceptance of the death, or waiting just for, or waiting for a family member to arrive, like, is there a difference in these reasoning?
So what about nurses taking care of the body for a week? Yes.
So I actually had a patient who was in the SICU that was brain dead for, it's been like over 2 weeks or so, and the team was really trying to push for the family to make a decision, and it was really hard, and we had like 3 or 4 family meetings where the first one was about 20 family
Right.
members, and it was very emotional and a lot of crying and yelling and just a mess. And then we had a smaller one where we thought we made some headway, and then we had that same thing, but she wasn't an organ donor, so it was a little different, but it still was like she was just existing, and this team was saying like they didn't want to keep having to like do the test for stimulation, and they were really just pressing on her sternum to get arousal from her and
Yeah,
taking
right.
her on and off the oxygen to do like the tests, and it became just too much. But I think in that situation, I feel like it should have been less than a week or two. But in this situation, I feel like because the family was coming from a different country, maybe like a week, meaning 5 days, not week 7, like could probably be a little more accommodating.
Okay, let's bring up the other questions. And I think we have one more. You asked, you said, depending on the situation, we may have a prolonged time of the patient on the ventilator, like we've had several cases where the patient was pregnant, and we would actually, and the husband is requesting that we maintain the body until a safe delivery, and that has happened several times. The length of time on the ventilator gets into a lot of issues in terms of whether the family believed in the diagnosis or if there's religious issues. In New Jersey's law, they make a religious exception to diagnosis of brain death. Some religions, like the Jewish religion and some Asian religions, don't believe in brain death concept, and so that brings up other issues of how to honor the patient's, the family request not to turn off the machines. In a few cases that we had with those situations, like there was a Jewish family, and essentially what are the opposing issues on the other side that constrains honoring family requests for prolonged existence of the body on life support. There's family autonomy, respect for family requests. What are the opposing on the other side that would warrant not to keep the body on the ventilator for a long time?
Resources?
Yes, right. Resources, issue of justice, availability of ICU beds. So that's the opposing issues. There's also, as I alluded to before, resources with the nurses caring for a person who has died already. And to be sure, there is the issue that you brought up about grief, but we do grieve after a patient has died as well. So I think that's an important factor, but grief is a prolonged period. It's not something that gets accomplished within a few days. Interesting enough, no one had mentioned this, but she was of the Hindu religion. Do we know what the Hindus believe in when it comes to brain death?
I'm Hindu by birth, not enough.
Well, let me tell you.
Okay, please enlighten me.
If anything, the Hindu religion, that's why I brought you here, but believes that the death occurs when there's loss of the higher cortical functions of the brain. So even if you have brainstem reflexes and you've lost your higher cortical functions, because they believe in an afterlife and people come back, so no problem. people die when they've lost a higher cortical function. So, and in fact, they believe very much in organ donation, and not surprisingly, she was an organ donor. So the hospital policy says 24, 48 hours. Try to limit, give family 24, 48 hours to accept this diagnosis. So next slide. So we asked the hospital their thoughts, and the hospital advised a shorter waiting time period. Ethics got involved, and we also believe that since there was no pressing religious issues, and we didn't know when this uncle from Guyana would come, we thought that actually in a previous case, the family taught me something when they went to court to get a restraining order to prevent the hospital from taking the patient off the ventilator. And as it turned out, we had a hearing before a judge, and essentially the family, who at times may not trust the diagnosis or may not trust us, this is a way for them to get due process and get a neutral party involved and deliberate the case. I always like to give the family an option to go to court and get a restraining order and have the case heard before a judge, a neutral party. So another family meeting held on Monday, and through a process of negotiation, we Thursday was settled, and actually several days were needed to do the necessary testing for organ procurement. And that did occur on Thursday, yes.
And family was all very, they wanted to have a compromise. They didn't want to go to court. They really wanted to reach an agreement, and it did come to light that this uncle, the earliest flight he could get in was Thursday morning. And so there was an agreement that, given the living legacy process of blood draws and evaluation and assessment and bronchs and all of that, that it would take a couple of days to evaluate anyway. So we were able to say, unless she decompensated and needed a more rapid process, the earliest procurement date would be that Thursday after the uncle was able to come see her.
Okay, and so a week later, the team got a note from the father. The father asked that the nurses be recognized as outstanding staff members. Father said that staff treated his family with such tenderness and care, which made things a bit easier for them, and the family supported the gracious decision for her to live on in others through organ donation.
And she was able to donate her heart, liver, lungs, kidneys, and corneas because she was so young. And then the autopsy did end up showing a right MCA aneurysm that had ruptured, causing the bleed.
So did she have severe increased intracranial pressure during prolongation on the machines?
No. Yeah.
Okay. I was thinking there will be herniation because of SAH and ICH.
Okay, any other final thoughts? Yes?
I don't think the family asked this, but what if they asked for a second opinion if they didn't believe their diagnosis?
For the brain
Brain
death?
death.
good question. So, outside of the hospital? Well, one could always get a second opinion, another testing. In fact, there's been several court cases in which the family didn't believe in the diagnosis, and the court ordered a second opinion, and actually the second opinion disagreed with the diagnosis of clinical brain death. So it's because they thought the patient was actually responding to voice commands. Okay, so it's been the whole issue of brain death is very controversial. Also, I was reading an article one time, how much of the brain has to be dead for clinical brain death? Because not all the activity of the brain is shut off, even though you have clinical brain death. Because it just tests the brainstem reflexes, but you have neuroendocrine action going on as well. One last question.
Do you think that this would have had a different outcome, especially the amount of time, like waiting till Thursday to reflect support, if the woman had not been an organ donor?
Different outcome. Tell me what you're thinking about.
I'm thinking about within 6 months, my family lived this scenario about North Carolina, and a 15-year-old boy, bad car accident, head injury, and the families moved along, and they decided not to donate organs, and within 24 hours, the hospital ended life support.
And it's the ventilator support,
Correct.
not life support.
Correct.
And so, I mean, the reason why the hospital waited till Thursday was because it took a couple of days to do the testing for the procurement. If she was not a organ donor, I think it would be appropriate to turn off the machines by Tuesday or Wednesday. I really think that in order to really proceed with the grieving process, I think that one needs to, get on with the turning off of the machines. Well, let me go with the next case. Is it appropriate to use HCV positive donor organs? It's organ day. For an HCV negative patient who has been on the transplant list for 6 weeks. Patient is a 50-year-old, history of idiopathic cardiomyopathy with a low ejection fraction, presented with chest pain, end-STEMI, and he also had end-stage renal failure receiving dialysis. When he was admitted, he was listed 1A on the transplant list for heart and kidney, and per the team, the plan was that the patient would remain in the hospital until transplanted. Hospital course, complicated by heart failure, had to go on VA ECMO and LVAD for mechanical support. Because of chronic infections, the patient had been deemed unsuitable for bridging by ventricular mechanical circulatory support. So the patient had been on the transplant list for 6 weeks when the case was presented to us. Surgical team is concerned that the patient will die waiting for suitable organs. They would like to expand the donor pool by considering the use of an HCV positive donor organ. In other words, a patient who is HCV positive, even though the patient is HCV negative. So, what do you think of that? What are the issues that come up when considering this? So, in doing this analysis, what are the issues against the use of HCV positive organs in a HCV negative recipient, and what would be the reasons to do it?
We're giving somebody a disease, like one of the cons is giving somebody a disease they didn't have.
That's right. Excellent point. Right. Are we in the business of giving diseases to patients? Also, HCV is stigmatizing, right?
But it's treatable.
It's what? Ah, okay. On the other side of the coin, it's treatable, with, especially with the recent antivirals. Other thoughts?
He's gonna die if you don't get it.
Imminent death, yeah, exactly.
Right. So the issue is that he's in bad shape, has been waiting a long time on the transplant list. So that's another pro. Some more cons or other pros. I'll take anything for now. Yes.
How old did you say the patient was?
50.
The main consequence of hepatitis C is over a long period of time it leads to cirrhosis. So if he's already, 50 or above, he may not ever even get cirrhosis.
Okay, good point. It takes about 20 years to get the complications of HCV. Good. All right.
What does the patient want? Does he want HCV or something?
Good point. So there's the issue of informed consent. Okay, and so that's always the issue. And the patient said, I'm tired of waiting. Yes?
Question, will him receiving an HCV positive heart affect the possible kidney transplant he'll have in the future? Will they transplant to an HCV positive patient? Yes?
Yes.
Okay.
The answer is yes?
Yes.
And why is that?
I don't know why, I'm so short, but I know it happens.
Well, sometimes they give patients who are HCV positive treatment before they get the transplant. So again, we have the availability of drugs. Yes?
And one of the reasons to yes is, we do liver transplants for cirrhotic patients that are cirrhotic from HCV. So it's almost like starting the clock over if the treatments didn't work for them.
Right, yeah, so now, years ago, when we only had interferon, there was a concern about rejection of the organs with the use of interferon. So here's the full list. The long-term safety of these the direct-acting antivirals are unknown. The DAAs do not stimulate the host immune system. Now, there is a cost issue, but there's also a cost with keeping the patient in the ICU for a long time as well. And we mentioned about giving a patient a disease, and we talked about stigma, HCV, and also the issue of a valid consent. And the pros is we do have these drugs, and emergent experience with kidney and liver transplants have demonstrated efficacy and short-term safety. And And we also mentioned it takes 20 years to cause serious damage. Did you guys see this slide before? Because you gave most of these points. Well done. And also prevent death while waiting on the transplant list. So if you add all of these factors up, we said that balancing the unknown long-term risks versus the benefits of shorter wait times that will prevent acute deterioration and death, use of hepatitis C, NAT positive, meaning even there's a difference between HCV only antibody positive versus HCV and also viremic, which increases the chances of the recipient getting HCV. We thought it was ethically justified, and we also recommended communicate clearly to the patient about the unknown long-term risk before giving consent. So the outcome was we gave this recommendations on Saturday, and the patient received the kidney and heart transplant on Sunday and Monday, respectively, and the organ donor was HCV negative. So it's like you enlarged the donor pool, and we didn't really even have to do that. And the patient is now awaiting discharge after the heart and the kidney. So okay, so another positive result. All right, so I'm sorry, I didn't show that. Donor status was negative. Okay, great. So here's another case. Is it appropriate to withhold blood transfusions from the patient? Patient is a 53-year-old African-American female with past history of hypertension, CKD, heart failure with preserved ejection fraction, diabetes, CVA, right breast mass, presented with out-of-hospital cardiac arrest. CPR was performed by the family on the scene. On EMS arrival, patient had an initial rhythm of asystole, which proceeded to PEA before we had return of the spontaneous circulation. In the MICU, she is receiving ventilatory support as well as CRRT. Family consists of the mother of the patient and the daughter of the patient, okay? 3 generations. So the team, hematocrit was 6.9, I'm sorry, hemoglobin was 6.9, and they approached the family for consent for blood products, although none was emergently needed at that time. The mother and the daughter said they were both of the Jehovah's Witness faith and would not provide consent for blood products. They did state that the patient is not a practicing Jehovah's Witness. So, what should we do? Yes?
Well, if it's not necessary for life-saving support at this point, then I think that in the interim, while they, wait for the family to kind of receive some more education, maybe come down emotionally slightly and realize, what is best for their daughter and their mother. But in the meantime, there's things that they could do, like take smaller blood samples, use pediatric tubes, start epogen injections, just do the best they can to fluid support her if it's not life-threatening at this point.
Right, yeah, so to be sure, there is time, but when push comes to shove, in the pediatric literature, if we have someone under 18 and the family is saying, don't give blood to our son, we're Jehovah's Witnesses, what do we do in that case? If it's life-threatening, do we give it? What's that?
We do it.
Okay, all right, just do it. Right, okay. So, could we learn from that situation to this situation?
You said cardiac arrest. Hopefully patient is not brain dead and there is some.
I would not give you another case of brain death. Okay. One is enough.
That's
Okay. I'm not gonna sneak another one in.
Okay, thank you.
Okay, all right. So, all right, so we, our analysis was that the family members were neither making a substituted judgment, that is, a decision based on what the patient would have made, nor a decision based on the best medical interest of the patient. And there was no other evidence that the patient was a card-carrying Jehovah's Witness. Usually Jehovah's Witness people would keep a card saying they don't want any blood products. So our recommendation was to tell the family that the patient is not a Jehovah's Witness and there is an obligation to transfuse when necessary. Emphasize that one would hold off as long as possible before blood products are given. And if the family objects, we recommended to contact the hospital's Jehovah's Witness liaison or ask the family to bring in their pastor for further discussions, okay? Now, as it turned out, the hemoglobin dropped to 6.2 and the patient is experiencing bloody brown drainage. GI consult recommended conservative measures for now. Now, in follow-up conversations with the daughter now reveals that when the patient was at Hopkins about a year ago, she had a transfusion reaction and started to refuse all blood products. So now the daughter is saying she knows for a fact, not based on Jehovah's Witness beliefs, but that the patient didn't want to have a blood transfusion. So what to do? So, if the patient had a life-threatening bleed, do we listen to this? What appears to be a substituted judgment.
So they're two separate things. Transfusion reaction is treatable. That's what most of us want to believe in, right? I mean, still a patient can have a reaction in that. But does the patient absolutely not want transfusion, or we will transfuse her and treat accordingly?
Well, the daughter is saying, my mother said she doesn't want blood transfusions. Yeah. In the past, she has said, I don't want to have blood products. So, if this patient has a life-threatening bleed, do we generalize from what happened a year ago to the present situation? Well, I see some people shaking their heads, so that's all you have to do, just shake your head, because this way, even though it's being recorded, nobody will know what the heck you said, okay, right? So, I like that idea, thank you very much, yes. Now, you're not afraid to talk, go ahead, and what is your name?
I'm Victoria, and I just wanted to know, did we look into her chart to see if she actually even went to Johns Hopkins? And
Yes, that was,
oh, so the story was very
yes, right.
Okay.
Good question, yes.
Are there any advance directives?
No, good question, yes. All right, so, now, let me just say that, On one hand, I felt, you tell me if this is correct. On one hand, I felt that previous wishes are important, and one would have to overrule the daughter, who is the legally authorized representative. Now, having said that, I mean, one could, Maryland law says that if a healthcare provider does, believes that an instruction to forego life-sustaining treatment is not consistent with the medical standard of care, that one could go to either the ethics committee or court. The question is this legitimate in this case? Yes?
I have a question about the withholding the consent. Was the daughter not wanting to like take on responsibility of like if she was afraid if I give consent that she gets blood and then she has a reaction that she'll feel responsible for that? Or was
Well,
it that she was like, no, I don't want her to have it at all?
I think that probably is going on, and to be sure, I think there's the issue of wanting to listen to your mother and her wishes, and this is what she said. Now, if it was just the Jehovah's Witness, going back to the beginning of the case, I know that family members don't want to take on the responsibility of saying yes and having issues with their religion and God. And sometimes they want the healthcare provider to say, we are doing this, and this takes the burden off of the Jehovah's Witness. But obviously, something else is going on here. And so what do you guys think? When push comes to shove, should we think about overruling the daughter? How many people would say yes? This is also not being visually recorded. So how many people say no, we should listen to the previous wishes? Okay, all right. There's a side of me that agrees with that. I thought that, now, does it make it, not a difference, but she was in a unit status post PEA arrest, not waking up after hypothermia. And let's say prognosis is not good, and she starts to have life-threatening bleeding. Do we give blood? Would that make a difference? Do we consider the benefit in our decision to whether to overrule the daughter?
So the question I think is futility of care versus.
Well, not futility. I'm just saying, we're not there yet. We're just saying that the benefit is less because the prognosis is worse. So do we factor that in the analysis? What do you think? Should we consider that? Yes?
So that depends on how aggressive the daughter wants to be with the management of her mother in discussion with the medical team.
What do you mean?
Well, does she want all life-sustaining treatment offered to her mother?
Well, she's refusing, she's just refusing the blood transfusion.
But she's not refusing continued care with ventilator assistance.
That's right.
Cardiovascular
That's right.
support, antibiotics if she gets an infection.
That's right. Just the blood.
Oxygen therapy, continued renal replacement therapy, those are all on the table.
That's all on the table.
So blood transfusion's on the table, in my opinion.
Because one has to be
Because
consistent.
if you're going the distance,
That's
you don't
right.
stop halfway.
Right, okay. Now, does the likelihood of benefit change the analysis? So now, on one hand, we got the benefit for the patient. On the other hand, we have the daughter trying to respect a mother. Also, another proposed wrinkle is, what if the patient was awake and was saying, give me everything except for blood? Now, I bring that up because patient wishes directly given to us, patient autonomy has more moral authority than surrogate autonomy, okay? But having said that, does the likelihood of the benefit change and whether we overrule the daughter? How many think that maybe that might be a factor to consider? Yes?
I was agreeing.
What's that?
Just agreeing that it's a factor.
Oh, you are agreeing. Okay, all right. I won't ask you for your name. Okay. Well, let me. I think it might. Because you're doing a balancing. I agree with you. All things considered equal, everything should be on the table. If we're gonna go all the way, but I think as the likelihood of benefit decreases, we're weighing two things. This is what ethics is all about. We're balancing, we're giving weights, the pros and cons, just like in the HCV patients, okay? So we're balancing benefit to the patient versus all the other stuff on the other side, which is trying to respect what we think might be patient autonomy and as being conveyed by the surrogate. So, the patient was critically ill, became on crutches, and she died several days later, never having the need for blood transfusions. And so maybe there was divine intervention in preventing us to make that decision. So anyway, it is 1 o'clock, so thank you very much for your thoughts. Okay. Enjoy the Thanksgiving holiday. You didn't know what the Hindus think?
Yes. As they say, off the, where can I be, where is this being recorded? Like, can we on the other side here? Not that I would.
Yeah, good question, because let me just see. Let me just turn this off. Yeah. Let me click that in here. This is a lousy one. This click.
Right here, this person?
Yeah,
and
right,
maybe-
yeah. Oh,
No.
no.
I'll start recording.
Can I just close this here?
say?
No,
What do you say?
those are the slides.
Oh, okay, I can actually start recording like this.
Yeah.